Okay. We're going to go ahead and start, and we're going to start with House Bill 1339. Chairman Butch Parrish. Which number is that? 4. Okay.
Thank you, Mr. Chairman. First of all, I want to thank the chairman and the committee members for allowing me to come before you today to present House Bill 1339. Before I get into the bill, though, I want to thank some people who worked very hard and put in many hours to get us where we are today on this legislation. Our House Budget and Information Office, especially Morgan Hall and Amber Mack, Haley Gala in the Speaker's Office, and our Legislative Counsel, Betsy Howland. And Betsy, we couldn't have done this without you for sure. The substitute that we're going to be talking about today is LC 339687S. And this is what we have before us today, and it's a bipartisan bill based on findings from the Georgia House Study Committee on Certificate of Need Modernization that met over the summer. As many of you know, CON was first mandated by the federal government back in 1974, and shortly thereafter adopted by Georgia and all of the states. The feds repealed the mandate in 1986, and subsequently the 50 states have gone their separate ways in repealing, amending, or continuing the CON regulations. Georgia has since modified its regulations several times, but given the rapid evolution of health care in this country, it's wholly appropriate that we investigated the structure and regime best able to provide Georgians with cutting-edge health care that's both accessible and affordable. As Speaker Burns has articulated on many occasions, improving health care access in Georgia is one of his top priorities. This CON study committee was a bipartisan committee made up of 7 House members and 4 non-legislative members with health care experience and expertise. The committee was intended to be a vehicle that would move us all in the same general direction, making improvements, clarifying ambiguities, and putting behind us as many roadblocks as possible. What we wanted to do in our study committee was to study the issues and the opportunities from every point of view, which included holding our first meeting in Atlanta, then we met in Augusta, and we met in Albany to ensure full consideration of various situational perspectives. Our final meeting was held back in Atlanta in late December, and our report was adopted unanimously and signed by every member on the committee. I have a copy of that report. It's been posted online, and every single member that was on the committee has signed that. There was a lot of work that went into that, and I appreciate everybody's hard work on that. I believe the findings of this final report were based on facts, evidence, and fairness. And I don't have to tell anyone in this room that health care is a complex issue and there's no single solution, and it's certainly not a one-size-fits-all. The report was helpful in drafting legislative remedies that encourage providers to offer preeminent health care, whether it be routine, emergent, or traumatic, and that is more affordable and increases accessibility to all of Georgians. Many of you were here last week when we had just a hearing on the bill and heard from several who offered suggestions to improve the legislation, and that's the reason we have a substitute here today. We listened, and many of their concerns and suggestions are incorporated into this bill that we have before us today. I believe, based on the feedback from members, policy experts, healthcare organizations, and stakeholders across the state, this is a very good piece of bipartisan legislation that will improve healthcare outcomes for Georgia across the state. And now, Mr. Chairman, I'll go ahead and present the substitute if that's
yes, sir. Go ahead.
The substitute that we're dealing with today, the House Bill 1339, modifies and updates statutes relating to the state Certificate of Need process. The Department of Community Health is required to review and update the state health plan every 5 years. The time period to submit a letter of intent is reduced from 30 to 25 days before application submission. The 120-day period for DCH to review the application begins upon receipt of the application, and within 30 days of receipt, an applicant will be provided an opportunity to meet and review with DCH. Opposition is required to be submitted within 30 days of the receipt of the application. Expenditure thresholds for the construction, remodeling, and installation of capital projects are removed. House Bill 1339 expands several provisions relating to CON exemptions. The allowable period for a closed hospital to be repurposed without a CON is extended from 12 to 24 months. The expansion of hospital bed capacity increased to 10 beds or 20% within a 3-year period when the occupancy rate exceeds 60% of the previous 12 months is exempt. The maximum distance for certain healthcare facilities to relocate without a CON is extended from a 3-mile radius to a 5-mile radius of the original location. Psychiatric or substance abuse inpatient programs or beds for Medicaid and uninsured patients are now exempt when an agreement is reached with a nearby hospital. New or expanded rural hospital-based obstetric services are exempt under certain conditions. Acute care facilities in rural counties are exempt under certain circumstances. Transfers of existing beds and services are exempt when they occur within the same hospital system and are within the 10-mile radius of the original campus, provided the exemption has not been used in the prior 24 months. Noncompliance is addressed in Section 6 of the bill. Failure to meet one or more of these requirements for exemption results in a monetary penalty. Repeated failure to pay fines or produce data lead to the revocation of the exemption. Penalties associated with delayed or unsubmitted reports are increased from $500 to $2,000 per day up to 30 days, and from $1,000 to $5,000 per day for every day after 30 days. DCH and the General Assembly's Office of Legislative Counsel will review and make recommendations to update and rewrite Title 31, Chapter 6, and other such provisions relating to CON in consultation with relevant stakeholders. Recommendations will be made to the General Assembly by December 1, 2024. Under the Rural Hospital Tax Credit Program, the DCH Commissioner shall approve proportional donations to an individual rural hospital if the contribution exceeds the yearly maximum contribution amount. The maximum limit on the Rural Hospital Tax Credit is increased from $75 million to $100 million per taxable year, and the sunset is extended from December 31 to December 31 of 2024 to December 31 of 2029. Lastly, House Bill 1339 creates the Comprehensive Health Coverage Commission, which will advise the General Assembly, the Governor, and DCH on matters related to the quality of and access to health care by low-income and uninsured populations, including reimbursement, funding, quality improvement, and service delivery enhancement opportunities. The commission will consist of 9 members, including a chairperson appointed by the Governor, 4 non-legislative members appointed by the Speaker of the House of Representatives, and 4 non-legislative members appointed by the President of the Senate. The Commission's initial report will be submitted no later than December 1 of 2024, and the Commission will be abolished on December 31, 2026. Let me just tell you, folks, I don't have to remind you again, this is a complicated issue. We have made changes and tried to accommodate as many of the technical changes that have been suggested to us, and a lot of the things that were suggested were mostly technical in nature. The bill is still basically in its same form, but we've clarified some issues and we've changed some technical issues there that needed to be changed to bring it up to speed. And Mr. Chairman, that's the first presentation of the bill. Be happy to answer questions or whatever.
Thank you, Mr. Chairman. You do have a question.
Okay.
Is that you?
Yes.
Okay. Chairman Newton.
Thank you. Thank you, Mr. Chairman. And Chairman, I appreciate this bill. I'm just looking in particular on pages 22 and 23. I know three of the areas that we have struggled with in Georgia, healthcare-wise, are our mental health and substance abuse. We've struggled with maternal mortality and how to better care for the prenatal care for unborn children as well as for the mothers, and finally, care in rural areas. And I just really want to tell you how much I appreciate us moving in that direction with these new lines and those new sections that allow people to come invest in all of those areas and try to meet those needs of Georgians. I really appreciate that. I do know a lot of stuff a lot of care has moved outside the hospital, and I know there are those that are interested in care outside the hospital, whether it's outpatient facilities or something like that. And I know you've been very gracious to work on this bill in a very collaborative manner, and I want to say I appreciate that, and I look forward to supporting this and seeing us, especially as we move on through the long legislative process, if we can look carefully at outpatient improvements as well as these great inpatient improvements that really, like I say, focus so well on those needs that you know better than most, but on maternal care, mental health care, and rural health care in Georgia. These are great steps forward, and I appreciate it, sir.
Thank you very much, Chairman Newton. And you're exactly right. We tried to take the suggestions and the feedback that we had from stakeholders and those that were interested to make the changes in here to accommodate their concerns. And those two issues, the behavioral health, mental health, and the OB, maternal mortality, are two of the things this House has been trying to work on for years. And honestly, I think everybody in the House can be happy and feel good about the fact that the House has led the effort in this General Assembly for years to move health care forward, and not only trying to see that people have access to health care, but we've got to have workforce out there to take care of the people when they go and seek this workforce. And we've got a new medical school going in Savannah. We've got a new dental school that's going down there. We're constantly increasing the number of residency slots in this program to turn out more providers, doing the same thing with the nursing schools around the state, as well as our mid-level providers, our PAs and nurse practitioners. So this House can be very glad and proud of what we've done in the past to help move that in the right direction. And this truly is just the beginning of the process, and we'll be moving in that direction. But I think it's a great piece of legislation. I sure would like to have y'all support.
Okay, no other questions. We're not going to take any testimony on this bill today. We had a full, excuse me, we have another late question. Go ahead, Leader Beverly.
Thank you, Mr. Chairman. Thank you, Mr. Chairman. I have just a few concerns and a few questions. Number one, thank you for bringing this bill. I know we've been talking about this a lot, but the two concerns I really have. The first one is, as we speak on maternal mortality, currently I think in the state of Georgia there are 3 birthing centers, if I'm not mistaken. Is there a reason why these birthing centers are not sort of qualified or as sort of critical access hospitals? Because I think there's some issues with transfer agreements between hospitals and birthing centers that we need to address. And so I know it's not in this bill, but I want to go on the record saying that needs to be addressed. And how do we address that? I know it's got to go to the Senate, but that would be one thing that we have to look at because of the situation is very dire in rural areas.
Thank you, Chairman. I appreciate you bringing that up, and we talked about this. And certainly there's some folks who want to use birthing centers. That's their option. That's what they want to do. And they can get a CON right now under the regulations. The only provision is they must have an agreement with a hospital in case something goes wrong and they need a transfer. That's been the issue, and I think we'll continue to look at that and continue to work on it and try to make that better, because we want to do everything we possibly can to get better outcomes and better results with this maternal mortality, and that's a great point. And I want to thank you for signing the bill with us, working on the committee with us. It's been a real bipartisan effort, I believe, and thank you for that.
Indeed, thank you. And I had one follow-up question for as far as the report is concerned. A few years ago, I guess I've been up here a little long now. In 2018, there was a report by Mueller. You guys remember this Keith Mueller report, designing a high-performance rural health system in Georgia. So as we start to look at a new commission and a new committee, again, we've studied this a time and time again. Medicaid has to be expanded, and I'm saying this on the record. Look, it's a little bit of a dereliction of duty for us as a community to not deal with this now. We had this report from Mueller in 2018. I would ask that when this new committee comes up, we start with that, and let's move forward. There are, not to get on a Democratic soapbox, but it seems like I'm on one. There are 500,000 Georgians right now without health care. And we need to do it, and we can do it now. We already have the report. So, Mr. Chairman, I would certainly hope that we start with the Mueller report. It's ready to go, and we teed up to expand Medicaid now.
Well, thank you for that comment, and we certainly want to do it. And the advisory committee that we're setting up in here, that will be specifically their job to make recommendations to the General Assembly, to the governor, so that we look at all that. But I want to go back to the fact I mentioned earlier. This House has been a leader in expanding access to health care all across this state for years, not just this year, but many years in the past. And just if we expanded Medicaid, if we don't have the providers out there to take care of folks who need health care, we hadn't solved the problem. We solved part of the problem. So we're going to continue to try to do all that we can to solve the whole problem, and thank you for your help in that.
Anybody else? Okay. Do I hear a motion? Oh, first, I want to thank Chairman Parrish for all the hard work. This has been unbelievable amount of work over this summer, and especially the last 3 or 4 days. My phone is still hot from all your texts and calls, but thank you so much for working on this. It's a tough subject. Do I hear a motion?
Yes, so moved, and love what he's doing as the rules chairman.
Yeah. Do I hear a second? All right. All those in favor say aye. Aye. All those opposed? Okay, the ayes have it. So House Bill 1339 passes committee. Thank you.
Thank you very much, members of the committee, Mr. Chairman.
All right, up next, Representative Mathiak with House Bill 1363. And if you want to do it from there, that's fine, or you can go to the end, whatever you would like to do. All right, go down there then, yeah.
You need your stuff. Get out your way. What's up, buddy? Already? Prime what? Burning. I did some plowing yesterday. Get ready for it. I'm gonna do some burning on a good day.
Low humidity, good sunshine.
I told my guy up there with forestry, I said, tell me when the day's right. I can't be watching it.
30 to 50% humidity.
Mm-hmm. 1363, right?
Yes. Yes. Thank you. Are you ready, Mr.
Yes,
Chairman?
ma'am, go
Okay.
ahead.
Thank you. Thank you for hearing this bill today. This is another bill that was not easy. It has a lot of information and a lot of phone calls, a lot of writing, a lot of learning for me especially. I want to introduce Mr. Greg Raybold. He's going to be helping me today with some of the technical things that are attached to this. But let me give you a little idea of where we are. The Georgia Pharmacy Association and the American Pharmacy Cooperative are discovering drug pricing manipulation in the Georgia State Health Benefit Plan. This is specific to Georgia State Benefit Plan, if you will try to keep that in the back of your mind. The data uncovered reflects massive disparities in generic drug prices with massive inequities that the state pays retail chain pharmacies as opposed to our Main Street local independent community pharmacies. Most of you got the one-pager last week reflecting the 15 commonly prescribed generic medications that compares the average chain payment to the payment to independent pharmacies and reflects the average chain pharmacy payment to those of the generic forms, often being hundreds of percentage differences in those payments to the independent pharmacies. This bill looks to bring stability, transparency, and savings to the prescription drug pricing in the Georgia's Health State Benefit Plan, while at the same time stabilizing our independent pharmacies. The bill would require an actuary study of implementing the National Average Drug Acquisition Cost, or NADAC, index model, which is an index administered by CMS, which is Medicare, I think you all know that, and used by most states administering drug prices and Medicaid fees for service programs. If the study reflects the cost neutrality or savings, it will bring the bill would require the Department of Community Health to move to NADAC, to the NADAC model in July of '25. As people were bringing information to me, and I'm not sure, Mr. Raybold's going to have to help me with this. I don't know if we got the information of dispensing fees particular. One of my small pharmacies at home, when I got that information, I said, okay, I want to know specific, what is it that you're being paid for dispensing fees? Now, that's different than the drug itself. And he indicated that he gets paid either 0 or 10 cents per prescription. So I want us to realize that that's part of what that actuary is going to look at as they look at the whole dispensing of medications and the reimbursement to our pharmacies. So with that, I think I would like to have Mr. Raybold give us his information. Are you going to go through the bill itself, the changes?
Happy to do that. I
Okay.
also have a short presentation as well, but
Okay.
I'm happy, whatever the chairman's preference is.
Would you rather hear about the bill changes first?
Once you speak to the base of the bill, and then let's talk about the changes.
Okay, go ahead.
Yes, and Mr. Chairman, thank you so much for your leadership on this, for taking the time to hear this bill. The bill in concept is a simple one. We've uncovered massive pricing disparities in the state health benefit plan between what independent pharmacies are being reimbursed and, of course, what chain pharmacies are being reimbursed. And I'd just like to note, before I get into the detail, we do have a bunch of pharmacists here on this issue. Is that important to them, including Katie Bell from Bell's Family Pharmacy in Tate, Georgia, whose pharmacy is featured there. What this legislation looks to do is it looks to require an actuarial study to the potential savings of moving to a NADAC plus model. As Representative Dr. Mathiak indicated, the NADAC model is administered by CMS via Myers and Stauffer, and it is a pricing benchmark, and it is, we would argue, the most sort of transparent national pricing benchmark that we have in this country today. Certainly not perfect, and happy to talk through that, but it's represents a marked improvement to the pricing disparities that we're seeing in this system today. If this study shows savings, the actuarial study shows savings, or if it shows neutrality, what this bill would look to do is mandate that the program move itself into the NADAC plus model effective July of 2025. And yeah, happy to walk through a little bit more of the detail of what NADAC is for the committee if now is the relevant time, or happy to hold on that.
I think I'd hold on that.
Okay.
Does the committee want to hear? Let me ask Al. Hold. Okay. Hold on that.
Yeah.
You do have a question. Chairman Newton.
Thank you, Mr. Chairman and Greg and Chairman Mathiak. Thank you. The prices listed on the sheets that I know everybody may not have them, but just for one of the cholesterol medicines that's $47 at the closest retail chains and $1.90 for the independent pharmacy. I did see one example on your presentation where you do compare it to that national acquisition cost, NADAC. On some of them, is it that they're paying the independent pharmacies too little? Paying the independent pharmacies too little, or dramatically overpaying the chain pharmacy, or is it a little of both? Or
Yeah, thank you, Representative. I think it's a little of both, frankly, right? I think there's no question that independent pharmacies being cut to the bone on these drugs. And I would note these are not one-off drugs. These are drugs that our independent pharmacies are dispensing every day, over and over and over again, right? So these aren't cherry-picked. We looked at the 15 most dispensed generics, or top 30 most dispensed generics, and we pulled from those, and there's more of those out there as well. But to answer your question, when you compare the reimbursements to NADAC, and I do have a comparison if you'd like to see it, but when you compare the reimbursements to NADAC, what you will see is, first of all, there's massive pricing disparity, right? So you've got 15 different drugs at 4 pharmacies, and you've got 57 different price points. So they are literally all over the map. I would go so far as to say the PBM is essentially making the prices up, right? There's no rhyme or reason when you've got 4 pharmacies, 15 drugs, and 57 different price points. But when you compare it to NADAC, and this is just those 15 drugs, and you look at the highest reimbursements, the highest reimbursement total was $889. The average pharmacy reimbursements, including Bell's and the other 3 pharmacies, was $471. Bell's farm reimbursement total was $192 for that. $192, unsustainable, and that's why we have members closing. If you run those same drugs, those same 15 compared to NADAC, you get a much more stable price, right? NADAC plus, and when I say plus, you've got the NADAC ingredient cost plus $10.64 dispensing fee. And that's what this bill contemplates. And when you run NADAC plus $10.64, you come out with a much more reasonable $384, much closer to the average. But so you certainly see some chain pharmacies getting paid, I would say, significantly over probably what they should. And then you've got independent pharmacies being essentially cut to the bone, being paid in line more with, say, mail order pharmacies.
well, just if I may, Mr. Chairman, the numbers when I saw these the first time they were put on our desks. They were really shocking. It really, the idea that, well, here's one, just a common cholesterol medicine, $14 is that NADAC, $89.98 to a chain pharmacy and $1.90 to an independent. They're so random that it's amazing that they're true, and no one's come out in the last week and said these numbers were not true. So I want to applaud you for getting a bill done, getting it done in time, and giving us a chance to look at this. This looks like a very thoughtful way to look at it very carefully, but we can't wait forever. Those independent pharmacies are a crucial part of the healthcare net, that safety net, if you will, in a lot of our rural areas that we all, as physicians, depend on to fill in the blanks. So look forward to working with you on it, and thank you for it.
Thank you, Representative.
Thank you. Is that you, Representative Kelly, at 8?
Yes, sir, Mr. Chairman.
Go ahead.
Thank you, Mr. Chairman. Chair Lady Mathiak, thank you for bringing the legislation. And I see the focus on the state health benefit plan is where we're primarily aimed today. Is that correct? Do we think that the state health benefit plan it only insures a segment of people in Georgia? Do we think the state health benefit plan has a practice in this model different than other health plans?
So Representative, what I would say is what we're seeing there are significant problems with PBM practices and PBM payment reform across market channels, to be sure. But what we have seen acutely, particularly since January, are members having these just massive under reimbursements from the state health benefit plan in particular, and that was the reason for the focus with regard to the state health benefit plan. I'd also note that obviously the state health benefit plan, because it's connected to the state, some of the pricing is frankly a lot more transparent, so it's a lot easier to make these comparisons, right? If I was an employer, if I was part of a different state or a Medicare managed care company, et cetera. I think this is absolutely worthy. Everybody should be looking at the prices that are being charged for drugs. And our position is, I think the proof is in the pudding when you look at these numbers, and these are not aberrations. Large PBMs cannot be trusted to set prescription drug prices. When they're setting prescription drug prices, what we see is obviously the independent pharmacies lose, the patients lose, and the payers lose. But most acutely, from what we're hearing from our members, and their doors are closing, is that this is a specific state health benefit plan problem right now. We lost Bell's Family Pharmacy about a week and a half ago. My wife and I were there the day that it was closing, the day before, and it was, one of the saddest moments in pharmacy in my life. We found out that in Cartersville this week, a 130-year-old pharmacy is going to be closing as well. And then we found out just today that there's yet another independent pharmacy that's 70 years old that's going to be closing in Forest Park, Georgia. So this is, these are not aberrations. These stores are closing, and they're facing massive downward pressure on reimbursement.
And I appreciate that, and I certainly am sympathetic as well. And that's why I wanted to make sure that we're being as all-encompassing as we can to hold these bad actors accountable. And if it's taking place in the state health benefit plan, we need to get to the bottom of it. If it's happening in other health plans, we need to get to the bottom of it. So thank you for the legislation.
Yeah, thank you, Representative.
Chairman Knight.
Thank you, Mr. Chairman. To my friend I've worked with for a while, I want to go over something. If we take the example of the drug that Dr. Newton just mentioned, I think that was the example of the $1.90 reimbursement to the independent pharmacy, Bell Pharmacy. But if we look at this and we look at the across-the-board reimbursements from $89.98 all the way down to $1.90, okay? That's a wide fluctuation, and we see that the independent pharmacists obviously had $1.90. But if I'm based on correction, if I'm correct on this, if you'll go to a slide that's two slides, I think, beyond this one up there, one more, please. That NADAC, no, one more, sir. Back to, I'm sorry.
Hey, wait a minute. Come on. No,
I messed you up. Right there. That if we look at this, that if you look at this drug and you put it at NADAC plus, it would be $14.24. So if we know, according to what you're calculating and what we know, a dispensing fee of $10.64, it would be $3.60 for the ingredient cost, plus $10.64 for a dispensing fee would be the $14. So we can deduct from there that the cost of this drug is around $3.60. First of all, as an example, I'll point out to the committee that the pharmacy was reimbursed a total of $1.90 or got paid $1.90, okay? My question is, on the other chain pharmacies that obviously were paid across the board, but as high as 80-something bucks, were they paid by the patient, and was that the copay?
So, Representative, what we've seen is some differences there, but we've seen copays as high as $50 on that drug, with the state making up the difference, according to the plan finder.
But sir, wouldn't it be true in this case that if you had a drug that had a $3.60 cost, and quite frankly, the reimbursement to the pharmacy was $1.90, so they've got a little money there that they've already got, or clawing back, if you will. Would it be true that this patient overpaid on this drug? And again, I don't, the 89, let's say it was the 89.98. What would be the difference between the actual cost of this drug? And obviously there is no dispensing fee on this. So the patient overpaid, in this case, a Georgia employee overpaid, what, 88 bucks, 87 bucks, 85 bucks?
That's right. Yep. And listen, when you have those kind of disparities, and again, 57 different drug prices on 15 drugs, and patients make decisions, right? And adherence is directly linked to the cost of a drug. So when you have these massive markups, it absolutely has implications. And I'd also note that I don't think your average patient realizes that they're being overcharged that much, right? They go to the pharmacy they've been going, they get that price, they trust their insurance, to save them money. And they assume that their insurance is saving them money. And in these type of examples, if they go to the wrong pharmacy on the wrong day, guess what? It's costing them a lot of money. And I'd also note, this is not something that we've had really good conversations with DCH. I know they're looking at it. I know they've been hit with this fairly quickly, and they're working really hard to try to get to the bottom of this. I suspect it's probably not easy, and I suspect they're probably having some trouble in that regard. But what I would note is, this is a contractor with the state of Georgia, right? This is a contract with the state of Georgia. And I think it's safe to assume that if you've got a contract with the state of Georgia, you're hoping that they're doing what they should be, which is administering benefits in a fair way that's going to be to the benefit of Georgians. And here, they would have had no reason to look at this, but now that we've looked, I think it compels a deeper look, and not just in the state health benefit plan, but a lot of these other state contracted plans as well.
Thank you. And I guess one of my questions would be, in some of these cases, what has the administrator of the plan, in this case, I think it's CVS administers the the pharmacy benefit plan for the state of Georgia, what have they charged in these cases in other words, from the state plan also? Because here's what I don't think people understand. There's money changing hands from 3 or 4 different levels. And in the past, we and this General Assembly have called clawbacks, the steering, all of these items, and we play whack-a-mole. But in essence, they have several different revenue streams, and they just change definitions. And by contract, they can cover these things up, and who knows? But in this, I would curious, what is the state on the hook for? Quite frankly, I wonder. I think there's a fiduciary responsibility, even though that's a legal question, to the beneficiary. Okay? Yep. We're all supposed to be here for the beneficiary. And certainly I don't think the administrator of this plan is carrying out that in a fair manner. But we also have a responsibility to the businesses in this state. And I see my independent pharmacists back there. Okay? Our responsibility is to make sure the businesses in the state of Georgia are treated fairly and equally, especially when it comes to taxpayer dollars. Thank you, Mr. Chairman.
Thank you. Representative Cannon.
Conversations with independent pharmacies back home, and looking at the timeline, their biggest concern is what do they do in the interim between the findings between December 1st, 2024 and when if there's something that we find July 2025, so that's a year and a couple months, some change. What's kind of the suggestion to them to make it until July 1st, 2025?
Thank you so much for that question, Representative. And what I would say is it's duly noted, right? Our members are scared and afraid that they may not be able to make it that far. Obviously, when you're talking about system-wide changes, you want to move precisely, you want to move strategically, and that does take some time. But we do have some ideas, and Representative Mathiak, I don't know if this is a good time to bring it up, but we have been looking at an amendment that would basically say that under the state health benefit plan, independent pharmacists can't be reimbursed less than the average chain pharmacy reimbursement statewide. And we think that would provide some immediate relief, and we think obviously certainly equitable. Obviously, if you go back and you look at what some of these averages are here, it's going to get independent pharmacists up to a sustainable rate, but it's not going to be that they're not going to be inuring to the benefit of sort of the really, really crazy, super high reimbursements, outlandish reimbursements that we saw on the high side. It would put them right in the middle, but right in the middle is going to be what keeps their doors open for the next year.
Thank you.
Thank you.
Thank you. Chairman Newton.
Thank you, Mr. Chairman. And just to follow up, obviously nothing is preventing state health benefit from doing their own work on this right now. Hopefully they've heard the intent of the legislature to look into this, and I understand the methodical way you do this. I hope you would consider a friendly amendment. I would like this to go into effect, that actuarial approval, not start on July 1st, but as soon as the governor signs it, so that we can begin getting that data. There's nothing magic. It is the middle of a contract year, but for actuarial data and to study it and start gathering the data, I would like to start this last month. But in lieu of that, I would love to make an amendment, if you'd consider it a friendly amendment, to to see if Ledge Council could come up with language to amend this to have a start date. Since there's no start date mentioned, it would typically be July 1. I would like them to start the actuarial study. I would like to authorize them to do it, at least from this level, just as soon as possible, if the chair would consider that at the appropriate time.
Let's ask legislative council.
Yes,
How would we word that and where?
yeah, so we would add a new, between line 64 and 65, add, section 1A, and it would say, this act shall become effective upon the signature of the governor, upon, the inaction of the governor. And then we would add into the title on line 5, to provide for an effective date.
Thank you. That's, the state is both underpaying and endangering so many of our independent pharmacies through allowing this to go on. But at the same token, they're also spending an excessive amount of state funds on over 600,000 covered lives and state health benefits in the meantime. So this could actually be revenue neutral or much improved, because there's a lot more chain pharmacies than there are local independents, and it seems like it's getting that way more and more, and we'd like to stop that trend. So that's just the amendment I'd like to make, Mr. Chairman, at the appropriate time.
Okay.
Thank you, Representative. And I'd also note that, you know, when we looked at those NADAC comparisons, and again, obviously there's many drugs, and that's why you need an actuarial study to look. But despite showing savings, or on top of showing savings when looking at just 15 common generics, there's also massive markups in specialty, right? And I think this one, just to give you an idea, you know, we're looking at state health benefit plan paying $3,354 when the NADAC would have been $31.34. And oh, by the way, despite Georgia's anti-steering law, you'll notice that says specialty pharmacy right there, right? So while the community pharmacists are left with the overwhelming majority of low-cost generics where they're cut to the bone, you've got the PBM setting these massive markups over NADAC, 10,600% markup over NADAC on one drug, and community pharmacies aren't dispensing it, but I'll tell you who is, and I think that's also worth looking into, particularly in light of the work that this body has done to try to rein those practices in. Here we are. And so again, we believe that the actuarial study is the right thing to do, and we're confident that it will in fact show savings, and just so grateful for your proposed amendment, because obviously the sooner they can start looking, the better.
Chairman Knight.
Mr. Chairman, I'd like to go ahead and make a motion, do pass, so we can get on with amendments, of which we have one.
We got more people.
Oh, okay.
We have more people to speak to this. DCH is here, and I want to hear from them. And we got a couple pharmacists that traveled a ways to get here.
Absolutely.
So we're not quite ready for that.
I think we need to hear from them.
Do you mind if I ask DCH to come up, and then you can wrap up if you'd like?
That's great.
wanna
Thank you
do
for
that?
allowing everybody to speak, because I think this is important enough
Yes.
to hear
Yes, I agree.
everything.
Senator Dean Burke, would you like to come up and speak? And is Lori here? Yeah, okay. Why don't you both come up? You want to go to that mic? How about right there? Yeah. We'll get everybody to come up here.
Test.
You passed.
Thank you, Mr. Chairman. Appreciate the invitation to be with y'all, and good to see these members, most of which I would call my friends. And if I haven't met you, it's my loss. I would like to give the regards of the commissioner who had a conflict this afternoon with the governor's office that he couldn't get out of, and I think it's his wife's birthday. So if he's smart, he left early. I'm not sure he's that smart, but as somebody that's been married 43 years, I know what it takes, and mama comes first in my house. I want to thank Lori Garner for being here. She's the brains of the outfit. I'm the Chief Medical Officer at Department of Community Health, and one of my responsibilities is oversight of the State Health Benefit Plan. And I want to thank the Representative Mathiak for bringing the information forward, and Greg and Melissa from the Pharmacy Association for letting us know that these pricing discrepancies were occurring. We met with them, I guess, the week before last. We have told them many times that we wish we'd heard about this earlier. So I think that's important that there is this communication of these issues, and the department, of course, takes it very seriously. And I do think it's important to the degree we can to bring back the state health benefits call to action from the standpoint of our fiduciary responsibility to the taxpayers. And we do not hide from the fact that we feel like we've been very, very aggressive negotiators when it comes to the PBM to help control drug costs, because that's a big part of the healthcare spend for the state of Georgia and therefore our employees and retirees. So we have been, doing our best to negotiate the contract, and it needs to be clear that our contract is with CVS to manage this program. We have no contract or control over the contract between the PBM and the independent pharmacists. So it's just important for you guys to realize we don't control that. And we have asked several of the independent pharmacies that we have met with since this issue came to light, and have asked them specifically, do they think their contract with the PBM was broken during this process since January, when these aggressive price discrepancies have come to light, and they said probably not, that they are meeting the terms of their contract. So that's probably indicative of the market that we're in, and that independent pharmacists are at a disadvantage just from a buying power compared to a chain that obviously is a national organization, and they're buying their products by the millions, maybe billions, and the independent pharmacists are negotiating on whatever their volume of business. And I do want to make sure people understand that state health benefit plan prescription counts for some of these providers are small numbers. We're talking maybe 50 a month in some small pharmacists, 100 a month. And if we change that reimbursement $1 or $10, I don't know that it's going to make somebody wealthy or go bankrupt, because again, we're talking about small numbers across their book of business. In other words, nobody's staying open in Georgia based on the state health benefit plan, because our volumes compared to the total volumes of prescriptions that we cover is just a small margin. Now, obviously every community is different, and every independent pharmacy is different. In those that don't have much competition, they may have all the business there. But I do want to allow Lori to discuss a little bit of the background, because she is the director of pharmacy for SHBP and is the one that is most knowledgeable about these agreements, and with the feedback that we get from pharmacists when there's a problem. So she's the point of contact to investigate those types of issues. So I want to let her speak, and then we want to stand for questions, obviously.
Thank you. Mr. Chairman, so just to kind of, Dr. Burke has already sort of laid out the scope of how our contracts are set up and established, and just to kind of highlight again for you, the contracts with the pharmacists are held directly between the PBM, in this case CVS Caremark for our benefit plan, and the pharmacies themselves. We unfortunately do not have insight into those because we aren't a party of those contracts. So as not being a party of the contracts, I can't tell you specifically what the rates are involved in a specific contract with an individual pharmacy or even with an individual chain. We do know that generally speaking, both state health benefit as well as other large payers will renegotiate the terms in their contract, usually on an annual basis. It's just so you're aware of a process we go through on our side. We do what we call an annual market check. We do that. We launch it out in the summer. We take a comparator group of usually several other plans that are similar in size and type of membership for our governmental program, use them as comparators, what kind of pricing are they seeing in the market, and then we use that for negotiation purposes, just like most other large payers do. So you'll have consulting firms that do that on behalf of a lot of their clients. That's a lot of times, I think, why you see the PBMs make these more dramatic changes in their pricing, and it's pretty common for them to do so almost every January. But we do take that very seriously, and it is concerning if we see that they are taking significant, changes in reimbursement that impact the individual pharmacies or have significant disparities between the pricings going on. So we certainly have taken this information from Greg and the GPHA group to heart to take a look at, and have been trying to get our hands around the details, basically in a contract we aren't privy to. But, we're doing our best to really get some specific details and information as we can to kind of really get into the weeds, so to speak, on the issue that's been brought forth. And we appreciate them doing that with us.
Thank you. Dr. Newton. Chairman Newton.
Thank you, Mr. Chairman. And thank you for your work on this and for the fiduciary role. I almost think we have two separate issues here, I believe. That one is this unsustainable payment rate for independent pharmacies, which is a devastating thing in our rural communities in particular. But the other side of it is a medicine, as Chairman Knight mentioned, may cost $3.84. You got a $10 dispensing fee. Fair price might be $14.24. Go to the next slide if you can. The next one there that shows, it could be $14.24 might be a fair price to pay for this. But then we have one of the busiest chain pharmacies up there at $89. I'm curious though, could that have been $189 and we just wouldn't know it? I mean, how did it get to $90 and we didn't realize that maybe this is new information and there's no way to have known that in retrospect, but it's kind of like, where did 90 come from? Why not 2 times 14 or 28 or 58? It seemed like 90, like I say, on the next drug it might be 190 and we just don't know. It still costs $4, but.
Yeah, and Lori will correct me if I'm wrong, kick me on the table, but I think what we're looking at it, which is just because that's the way we have to look at it, is our total spend. We have control over how much we send to CVS total. We don't have control out of how much they are paying the independent pharmacist. So in other words, CVS could not overcharge us above and beyond what their contract allows them to charge us.
So do we have a contract that tells that they agree what they're going to get paid for atorvastatin?
No.
Okay, so that's not by drug. It's just that and you have a flat amount for 600,000 plus lives, cover all the pharmacy expenses, and how they divide it up is really up to them.
Right. According to our contract, CVS has to pass through to us the charges exactly as they're paid to a pharmacy. They can't, I'm sure you guys have heard the term spread, sometimes where the PBM takes a cut out of the payment. In our contracts, that's prohibited. So whatever they're reimbursing based on their contract with the pharmacy is a cost we pay, but we pay it based on, as Dr. Burke's saying, the total amount of spend for the state. We do not go to atorvastatin and say, we'll reimburse this amount for that single drug. Our contract doesn't do that.
But if I might, so we don't say anything about the specific drug prices, but
right.
Do we have a fixed rate for all the pharmacy benefits for 640,000 covered lives for the next year, or is it whatever they spend, they just tell you what they spent?
Right. Their
Okay, and you pay it.
responsibility under the contract is to negotiate market competitive rates and then bill us for those market competitive rates in total.
All right, thank you.
Yep.
Okay. Chairman Knight.
Thank you. And again, I appreciate y'all. I'm one of the ones that met with you a couple of weeks ago, and I do want to say I want to thank Dean and Lori and them for listening. I think they're taking this very, very seriously, and I really appreciate that. But in regards to some of the concepts here and the issues, you know, we talk about pricing in the market. And I think we're relying on CVS and them. We're going out to say, hey, we're putting that responsibility on you. We're paying you to rely on this. But I want to go back to the example that we have here. And before I get to that, there was an audit of DCH a couple of years ago, but on the front of it had this cycle, and it had what was actually driving the cost of our health care, okay? And one of the issues is when there's a illegal or a fake claim or whatever, it drives up the prices. But I would say, isn't it true that in actuarial, when we have prices that are inflated, that goes into the next year's actuarial calculation? And then if we have inflated prices, it's not only, you know, calculated based on past inflated market prices, but it continues to grow as we see examples. And I would go to this example right here. $89 for a $3.90, I think that was what my calculation was, a $3.90 ingredient cost drug. One, isn't this inflating the price? So if we're giving CVS the job of looking at this and trying to make sure that we truly have market prices, I would tell you this is probably a very, very poor example of that. And they're filling their duty to the state. But second of all, if I'm also not mistaken, and again, I know we're trying to get information and all, but if I'm not mistaken, that was come out of the patient's pocket, the state beneficiary, the beneficiary's pocket, the state employee's pocket. Okay? That's driving up the cost of health care to our state health employees, our state employees. That's not responsible. In fact, I would almost say that that is probably getting into unfair business practices. In fact, there's a whole legal section in Georgia that probably needs to be investigated in this situation. Not on y'all's part, but on the part of CVS and the PBM that has allowed a Georgia employee to go out and pay $89 for a $3.60 drug that came out of their pocket. And I don't understand that. I don't understand that at all. I don't understand how we're hiring these folks and there are no guardrails that says you've got to stay within this, or you've got to go back and review what you've done from a market perspective. Because I would tell you, whether it's $50 or $98 or $89, that is not market pricing. NADAC is market pricing, and that's the federal government. And I don't understand that. I say I do understand it. I know what they're doing. They're giving to some and they're taking from others based on whatever their contracts they're offering. But that right there is something that I think has got all of us very concerned. And it's had me concerned because I've seen it for years. And I've played whack-a-mole with these companies. And they change contracts and we can't see them. Maybe it's time to look at maybe a pilot program or another program where we have a true market-based, a true transparent PBM, in which maybe we try a pilot program and we give everybody a shot. Because I guarantee these folks in the independent pharmacists, they're already dispensing drugs at the lowest cost. And I guarantee you they can be competitive based on that right there. They're already competitive. They're already beating them. The evidence is there. The chains are getting paid more than the independents by a wide margin. And that may be a suggestion that we look at or you think about. I don't know, but I know this is not right. And I appreciate y'all's work because I think y'all are going to be the ones in the meantime that are going to have to help us get through this. And again, I'm sorry. This is, y'all know, Dean, you know this is one of my things I've been fighting for years, and it's very passionate. It's a very passionate issue. But
well,
I appreciate it.
I think it's fair to say that obviously the department takes this extremely seriously. It is our responsibility, and we don't shy away or back away from that, and we will investigate it to the degree that we can from a legal standpoint. And obviously the legislature and the governor's office will also be looking at these issues, and we'll work together on them.
Dean, one of the things I'd like y'all to look at is apparently in some of this information in the website that the payments to these independent pharmacists were spot on. I mean, it was exactly what, it matched. But the average the payments were all over the board on the independents. But this was spot on. I mean, this was, and I think it was across, if I'm not mistaken.
We've looked at the data, and that data is accurate. We don't have any. We're not arguing that.
So the independents across the board got paid the same thing for the same drug.
For those specific
for those
examples.
specific drugs. Yeah.
Now, I do think it's important. I mean, I've been part of this process for a long time, and both sides of this argument are going to pick out the examples that make their point. That's the process. That's what they're being, each side's being paid to do. Our job is to filter all that out and try to find out what's best for the state and best for the taxpayers, and makes the most sense, and to listen to everybody's information, and then come up with something that we think is fair and equitable, and with the policy parameters that are set by our governor and by the legislature.
Thank you. Representative Cannon.
Yes, thank you. Are there any incentives built into the contract with CVS to control pricing or lower pricing? And maybe if the contractor's paid based on a percentage of the expenses generated in the contract?
No, they're definitely not paid on a percentage. They are paid with financial guarantees in place. And that's how we get to that market competitive rate that I was talking about, is that, as a steward of the funds of the state of Georgia, our responsibility is to make sure that we're not paying above market reasonableness, we stay in line, and that's why we do that market check every summer. So we do use that for contract negotiations, and they have the pass-through amount that they have to pass through to us, regardless of, what, based on their contract terms with their participating pharmacies. And then they have to meet certain total financial guarantees. So what's an average discount off of the total generic spend for, a 30-day supplies versus 90-day supplies. And those are really across the whole contract, but it's a guarantee to be at that point of the financial guarantee. So it's not they get no fees based on lower rates across the board than higher rates. They just have to meet financial guarantees that they don't go significantly awry in how they price.
Representative Douglas.
Thank you, Mr. Chair. I just have some brief comments. I understand there's a blanket contract that you guys work by, but going forward, since all this have come to light, we should have in place something that's going to be amenable to the people that we serve, even ourselves, because we are dealing with tax dollars. And also, with us being the largest employer in the state, we should have the best pricing of anybody in the state because of the numbers, number one, and the things that we take for granted every day, and that's trying to do better for the people who sent us down here. I know Dean, we have a great relationship. We worked together in the past. This is my first time seeing and meeting you, but if we are good stewards over what we have and us serving the state of Georgia for our people, I think it would be amenable for us to do better on a health concept along with paying, because the simple fact is the less we pay, the healthier we, and it's not about us. That's what I want to get across to everybody. We're here so our future looks better. And based on this report that we just see, our future is not looking very bright. And so our kids and grandkids who's coming behind us will have a better shot of making Georgia a better place health-wise. Because you can make a lot of money, but if you don't have your health, what good is making the money? Because you got to spend all your money getting your health back. So I don't want to be on that wheel, a revolving system of, and I'm very passionate about this. I had something go on in my family where this affects everybody down the line, because you know when you have this insurance, some people that work with us are the insurers for their whole family, and so you know, and now we're over it, and then we have to go back home and say, hey, we've been stuck in the eye by these guys because we have a contract that we gave the responsibility to somebody else to negotiate, where we should be negotiating at the table on these contracts. So I don't know if that was a question or just me venting, but it sounds good to me, so I'm gonna stop right there. Thank you, Mr. Chair. And thank you all for what you do.
Representative Kelly.
Thank you, Mr. Chairman. I think kind of we're maybe on the same page here, and I got to the kind of question now that Chairman Newton brought up about the overpayment. I take Avorstatin myself, Lipitor, yeah, and so if I, and I'm on the state health benefit plan, so if I was going to, you know, one of our larger retail chains, the state's paying almost $50, 3 times what we saw the NADAC pricing. Is there concern that that could be driving up the premiums for the state health benefit plan?
I think we've already stated we are very concerned about these numbers and these issues. I think it's important to realize, though, that we have a contract that we're not paying more than X dollars, so it's not like this is they could charge $1 million a prescription and we just pay that bill. I mean, that's not how this works. So I think the state is, because of our use of a national company that has unbiased, doesn't have a relationship with the PBM, we use their expertise to guide us in the contract that we have with CVS, and their information they're giving to us is that we're protecting the taxpayers, because that can't be above a certain amount, but again, we're not telling that company, CVS in this example, how to spend that money. They are contracting individually with the chains and the independent pharmacists.
And I appreciate the job y'all are doing, Doctor. We have a great relationship going back a long way, and appreciate the commission, all of y'all. But if there was legislation that said that no pharmacy could be paid more than the NADAC plus, if we put forth legislation like that, what kind of impact do you think that would have on the state health benefit plan?
Well, I think just philosophically now, this is just coming from somebody who's got a lot of gray hair and been through a lot of these kind of discussions. You know, when you are in a position to negotiate contracts, the more limitations you put on us, the worse our contracting ability is going to be. So you do need to kind of be careful that you don't put the state as a disadvantage at that table, that because you said you got to pay this person X and you got to do this Y and this Z, that you end up with spending, 50% more for that contract the next year because of all those limitations. I think the policy decision here is that y'all have to deal with is, what to do about this discrepancy. We've got to make sure that our contract's being followed and that there was no breach of contract. And if there was, then we have a process to deal with that. But the decision of what to do about the fact that the market right now is valuing independent pharmacists less than chain pharmacists, that's basically what, in my mind, that's telling us, is a much bigger issue and going to be very challenging to solve.
Thank you, Dr. Burke.
I want to thank you all for coming today, and appreciate you listening to the committee and the questions. Why don't we have?
Can I ask one question?
Yeah, go ahead.
Can you walk me through how the contract comes about? Who negotiates it? Where can you walk? Maybe the Reader's Digest version, because I have a feeling that it's probably very arduous. But
Sure. We go through an IFP process, or RFP, whatever your acronym of choice is for request for proposals. We do that on a regular basis. I will tell you, COVID set us off on our timeline a little bit. Generally, it's about approximately every 5 years or so, and we put the business out to bid. So then we let the pharmacy benefit managers bid in. We work with a consultant. We have technical questions we ask. We have financial section. We score them completely separately. And in fact, we use the consultants to score the financial component of it, so that you don't have the same people making the same scores. And then the contract is developed with whatever winning bidder comes out of that process. Go ahead.
do you actually get to see the contract at the bidder end, or is it a proprietary?
We put a
agreement?
template contract into the IFP, so the bidders know what's in the contract to begin with.
Right.
And then when it's done, it is subject to open records, except of course for the financial disclosure that you could back into individual rates on, which they consider proprietary and trade secret.
Gotcha.
Yeah. Yes.
Okay, thank you. Let's, we've got some people that have driven here from outside Atlanta to speak to this, couple pharmacists. Let's go with them next, and thank you all very much for coming. I appreciate it. How about Scotty Barton? I know you've been sort of swaying back and forth. We'll let you sit down here for a minute.
Thank you, Chairman, for having me. First, I'd like to say, pleasure being here. I am an independent pharmacist. I've been an independent pharmacist now for roughly 20 years. Been in the business for a really long time, as you know. One of the things that I want to speak on, too, is somebody had said, is it other contracts that are literally a problem? Yes, there is. I'm just going to go ahead and tell you. But on behalf of all independents, when we get handed a contract, it's not a contract between me and you. It's a contract of you either accept it or you lose that population. And being an independent pharmacist, I want to serve as many patients as I can. Okay? So what I had happen myself personally was we filled 3 prescriptions at my store for my wife, so I can discuss this. She's a school teacher. At my store, those prices came back at $5, $7, and $18. When I filled those 3 prescriptions at what I paid for it, I lost $29 by filling my wife's prescriptions. So being proactive, we transferred them to Walgreens. So at Walgreens, when she went to pick them up, the 3 copays were $50, $50, and $50, which is $150 compared to the $31 that was mine. So when you get to digging into this and you look at it, Walgreens probably netted $120 where we lost 31 or $30, and that's pretty much the way it is. So I've got all this in a folder here. I can show anybody that wants to see this. This is my information. So I took it a step further. I called CVS Caremark, who is the provider of the state plan. When I got on the phone with them, I didn't tell them I was a pharmacist. I didn't tell them I was a business owner. I told them that I was the husband of my wife. And I wanted to know why, when we went to our local independent, it was $5 compared to the $50 that Walgreens got. They proceeded to tell me that's what independents do, is lose money. And that's the perceptions that's out there. So not only do we have that kind of perception going on with what they're doing as far as their contracts that we have no control over, that we're forced to sign. Because again, I do not have the population that a Walgreens or a CVS. I'm a business owner in a small town trying to make a living for all my employees and my family. Okay? So right off the bat, we're put at a disadvantage just by filling these prescriptions. I fill prescriptions every day of my life that I might pay $30 for, and I get reimbursed $2 for. And I think any of these guys behind me will tell you that is common practice at this point, because the thing that gets fed back to us is we need to steer those people away from my business. I've got a population who has been with my store ever since I've been in my store. I want to serve every one of those patients that I can get without having to take them out to a CVS or a Walgreens. And we can't keep allowing this to happen to us, because my store, I bought it in 2010. It's the oldest surviving independent in Gainesville, Georgia. We turned 70 years old this past January. If this continues to go on, I can assure you that that store will not be open in another 2 years. So we need your help. And it's the part of saying that they negotiate these contracts with us independents. That's not the way it goes. CVS Health will send out a contract. You either sign it or you don't. And if you don't sign it, you lose that whole population. And I know a lot of school teachers in Hall County, Georgia, because my wife is one of them. And for me to send that population out because I can't get a fair reimbursement is not fair to us. It's not fair to anybody. And one more thing that I'll say is they asked about the copays for my wife's prescriptions. The $50 that she paid was totally out of her pocket. Okay? That was 50, 50, 50. That was $150. My wife had the money. But we want to be concerned about the patient. You take a single mom who is a teacher in this state who knows no better than to go to Walgreens or Walmart or CVS. She's paying that $150 out of her pocket. CVS Health paid $0 to Walgreens, paid $0 to Riverside Pharmacy. So all of that cost got deferred back to the patient. And that's who we need to be concerned with. I mean, it's all about, at the end of the day, it's about the patient. But us as independents now, we're trying to fight with everything that we've got to make this practice of pharmacy better for not only the patient, but if I could walk away from my store today and make this practice of pharmacy better for everybody else, I'd do it in a heartbeat, because we're on a slide that we can't stop at this point.
Thank you very much. Okay, how about Jesse Weathington? You want to come up and speak to this?
Good afternoon, Mr. Chairman, members of the committee. I'm Jesse Wethington. I'm the president of the Georgia Association of Health Plans, which is the group that represents the commercial health insurance industry in the state. My members are in opposition to this bill. I would communicate that with the sponsor, my friend, earlier today. But our general position is, as carriers, that the bill is just not strictly necessary. If this is a study that the SHBP wanted to conduct now, they wouldn't need legislation to do so. You could do it in the budget as a direction, or you could just have a negotiation or discussion with the department to do this. I would suggest as well that the bill does need a fiscal note because it does have an impact on the SHBP's financial operations. Again, it contemplates an actuarial study, so to me that seems kind of self-evident that that's really what it does contemplate. But our position is that this strictly isn't necessary. You can do this financial analysis now. And really what this is about is that dispensing fee that's been brought up. Moving to the national average drug acquisition cost would represent a fairly significant increase in a dispensing fee for independent pharmacies in the SHBP. What I would say to you all is you're in the difficult position of having to choose between two competing priorities, which is the sort of financial operation of the state health benefit plan for its members who are public employees and is funded either by their premium dollars, their out-of-pocket dollars, or tax money. And then, the competing priority of economic development issues and the viability of independent pharmacies. I think those two things are in opposition, so you have two competing priorities here, and unfortunately that's the position that you're in as legislators. But I would say just have the study done. You don't need to pass a trigger bill that kind of sets up the outcome. If the desired outcome is what the study reveals, that's just strictly unnecessary, and we would say don't, again, put shackles on the hands of your department when they're trying to go out and run a large program in aggregate to deal with the fiduciary responsibility that they have to the public employees, retirees, and the other beneficiaries of the plan. Some of my colleagues from PCMA are going to come up and get into some more specific issues relating to PBM issues directly, but from a health plan's perspective, we wanted to put that out there that we didn't think the bill was necessary from an administrative standpoint.
All the lights went out, no questions. Thank you. Questions? Oh, I thought you turned yours off. Excuse me. He's got, Representative Newton.
Thank you, Mr.
Yes, sir.
Chairman. You mentioned the fiscal note. From the way I'm reading this, though, are you talking about the cost of an actuarial study, or are you talking about the trigger for the Section 2 that says if it shows a savings? Because
I would say the latter piece. I mean, the
so
actuarial study will cost
the
what it
trigger-
costs, but
but the trigger amount is only if it shows neutrality or savings. So at least the way the trigger that I read on lines 52 and following, it looks like if there's a cost, the trigger has no if it raises price. I think the biggest concern, and Representative Kelly mentioned it, is the question like for Lipitor, atorvastatin, the 116 million prescriptions last year, the leading prescription in all of America. That's not a small number of prescriptions like some of the specialty drugs. This is the most common drug in America, and it showed just a 4,000 times difference between what they pay one to another, and they pay a lot more to the higher one because there's a lot more of them. So I think didn't we deal with the fiscal note issue by saying that, or the author did at least, by saying if it shows a potential annual savings, so there's no fiscal note for I guess it could show negative, but if the study shows zero impact or of a change, then number one, get the information. You can't be opposed to getting information, I hope.
that's right. And I guess our point is largely that you don't need a statute to trigger a study like this. You could just do it.
But if it saves money, we want them to go on and take step 2.
I think we're totally fine with the state doing a study, and we'll cooperate fully. It's passing a statute to do something that you could do as a yes item in the budget. Again, this is other funds because it's SHBP. You don't have to mess with state funds, but there are different rules for how this program is operated. But you could easily accomplish this bill by putting a yes item in the SHBP budget.
Thank you very much. All right, how about Kevin Woody?
Thank you, Mr. Chair, for the opportunity to speak. As you know, I'm an independent pharmacist. I've got a couple notes here because I didn't know I was going to speak at this in your neck of the woods. And one of the things that we've been blessed with in our community is having individual providers take care of our community. You take care of our community. Your family does. And we're trying to do the same thing. Dr. Burt and Ms. Lori had mentioned not being privy to the contract. Well, they're not the only one. We don't see the contract either. We take it or leave it. But it's amazing. CVS Caremark, who administers this plan, happens to be my competitor. They have buildings down the road. So my competitor, who knows the cost of the drug, is reimbursing me far less than they are buying it, just like it's far less than I'm purchasing it. The example with the atorvastatin happened to be one of my clients. Same thing happened. I didn't have the medicine that night, so she said, I'm going out of town. Rather than wait for it to come in tomorrow, I'll run up the street and get it. I felt terrible. I said, I hope there's not a huge discrepancy in price. She comes back a few days later and she said, hey, there was no discrepancy. It was zero. But she said, what's weird is I called CVS Caremark and found out it was $89.99 or $88 to Walgreens. But her copay was zero because she has a health savings account. So they're burning through her account at quite a rate. Now, what brought my attention to this prescription is she gets 90 days at the time. The previous 90 days, I was paid $17, which was quite fair. I would say that was fair. Well, all of a sudden, the next time I go to fill it, I'm paid $1.90, and I'm like, something is terribly wrong. It was, and I realized what was going on. It was mentioned also by Ms. Lori that this is a small number. Well, that's a matter of perspective. The first of the year till now, I've filled 1,500 prescriptions at a loss for state health benefit. Now, to me, that loss was negative $7,000. But if you take the scale that we've looked at here today to any of my competitors, that's $90,000. That's not a small number. I would love to have that $90,000 in my budget, but it's not there because I'm not paid properly, and so I'm paid on an anti-competitive situation. CVS Caremark, as I mentioned, they own a pharmacy that is my competitor. They also enforce that I go through all kinds of hoops every year for fraud, waste, and abuse. They make sure that I'm not allowing anything to be spent in the wrong way through the Medicare programs, and I go through a lot of things. I go through a lot of audits. First of the year, the very 1st of January, I had a huge on-site audit with Humana, and I had 4 other very, very large audits, desk audits with these companies. All in the month of January to make sure that I'm not overspending their money. But we can see that these people are committing fraud to the state health benefit program. So when you let the fox watch the hen house, there's a problem. And we want to save money. I can tell you right off the bat, you don't even need to study. Take those numbers, divide them in half, and pay us all the same thing. And we just saved you a lot of money, and I'm going to stay in business for another year. But I certainly want to thank each of you for hearing this. There was a comment mentioned that it didn't get to you quick enough, and I apologize for that. It took us a while to figure out where the leak was. It took us this far from the first of the year. We knew something was wrong, and we were trying to figure out why. I went a whole month and a half, and I didn't draw a check from my 3 businesses, and this is why. It is a big number, and it matters. It wasn't a big number on my loss, but it was a huge number to my competitors. So thank you so much for your time. Thank you for looking into this.
Thank you, Kevin. Thank you. Michael Power.
Good afternoon, Mr. Chairman, members of the committee. Michael Power with PCMA. We are the national trade organization that represents pharmacy benefit managers. Our organization does represent close to 20 PBMs that operate across the country. Here today just to talk quickly about House Bill 1363, then happy to take any questions. Just wanted to flag a few things. NADAC is a national survey that CMS uses. It is a survey that CMS sends out to a random selection of pharmacies across the country with the response rate of that survey less than 30%. So I do caution you that while some of the numbers here that I had not seen until this afternoon and I have to take a closer look at, but it is a voluntary response survey. And so there are instances where NADAC might be below what a pharmacy acquires a drug for, and higher than what a pharmacy acquires a drug for. It's also important to point out that this legislation also calls for an increased dispensing fee. Generally, state health benefit plans or commercial market plans around the country pay on average $1.50 to $2 to the pharmacy to dispense drugs in the plan. If we went over to the Medicaid rate here in Georgia, I think it's roughly $10.64. And so that would definitely represent an increase in the program. And generally where we've seen laws like this pass in like West Virginia or Tennessee, the patients are actually paying that increased dispensing fee at the counter. And so I would just caution this body that, citizens of Georgia are also being exposed to that increased cost when a legislative mandate like this comes down. I should have said, as the bill is written, we are opposed. We're not opposed to the study provisions of the bill, but like Mr. Wethington pointed out, the trigger element, that if there is a savings, whether that's 1 penny or $10, this legislation or this new pricing methodology could be adopted into state law. It is important also to highlight that when PBMs negotiate on behalf of plan sponsors, which it could be you, the state, the federal government, businesses, unions, trusts, you name it, around the country, we represent about 275 million lives. Generally, when we negotiate with independent pharmacies, we negotiate with groups called Pharmacy Service Administrative Organizations, and those were initially established to actually really truly help independent pharmacies. But what we've seen as that market has grown, there's been consolidation there as well. The three largest wholesalers, McKesson, Cardinal, and AmerisourceBergen, own many of the PSAOs that represent a large share of pharmacies across the state and across this country. And they're in a unique position. They negotiate on what the pharmacy pays for the drug, and then they negotiate on a reimbursement that the PBM pays that pharmacy for that drug. And so I would recommend that, like South Carolina, this state maybe additionally look at some sunset provisions on the operations of PSAOs here in Georgia.
Thank you. Representative Newton.
Thank you, Chairman. You did mention the size difference. I guess I'm a little confused. Typically, when an organization buys millions of a product instead of a few hundred, you get a lower price. What we seem to have here is the ones that fill the most prescriptions, far more than the independents or the chains, and they get a tremendous higher price. I guess I'm confused about the normal pricing mechanism of volume discounts. We don't really think about volume premiums, that you pay more to somebody because they fill a lot. Usually, I thought you usually got a better deal when you did a high volume, but how has this gotten turned on its head to where you get 40 times as much?
I appreciate the question. I would have to look at the data set. The presentation today is the first time I've seen numbers like that. Generally, in our networks, independent pharmacies are reimbursed at a higher rate, largely in generic effective rate contracting. And so chain retailers usually are reimbursed at lower rates. So I would need to see the source of this data set to compare apples to apples here.
I think that shows what an actuarial study and making sure we could save money would help. Thank you.
Representative Knight.
I think that's what we're trying to do is get the data for you, because quite frankly, I don't trust you to go look at your own data. Second of all, how do you explain, as a PBM and you representing that industry, how do you explain the fact that you're there trying to supposedly, the fiduciary responsibility to the state, but we could also argue there are court cases, and I'm put it forth, and I could put forth another bill that would bring y'all to your damn knees, okay, about fiduciary responsibility to the patient. All right? And when that state health employee paid that much in a copay for a $3 and something drug and paid $50 on a copay, where is your responsibility from the PBM to the employee? And also, somewhat of a responsibility to us who fund the plan. Who's getting paid that? It came out of the employee, but yet their health insurance rates and their portion keep going up. Explain it. Explain it. Where's your role and where's your responsibility in that one? You're the one that contracted with Walgreens and with the other chain pharmacies. Tell me, where is your responsibility for taking $50 in that one instance out of the employee state the state employee out of their pocket for that? Where's your responsibility?
Mr. Chairman, I appreciate the question. Again, I have not looked at the data set on that study, and I would have to take a closer look at it to see how that actually works. And I'm not trying to blow smoke. I do appreciate the question. Generally, our role when we're hired by plan sponsors is to reduce the overall cost of the plan, not just to the plan sponsor, but also to the lives that they cover in that plan. When I was looking at this data from the back of the room, I couldn't tell where this information was sourced from. So I would need to take a closer look at it to see where this is coming from.
Thank you very much for coming in and speaking to us. We're going to go ahead and move to the office for a wrap-up. We've got another bill to hear. Smokey. Representative Mathiak, would you like to wrap up for us, please?
Yes, sir, I would. Yeah, we'll clear the smoke, Representative Douglas. I think you can see, everybody can see the major concern. I think the actuary is going to really be telling, and I'll give Michael some of the information that we've given you. I think our sources are on those handouts. I would like to see us push forward with that actuary so that we can see where everything's being spent. I personally am very concerned about proprietary contractual agreements because I think that we're going to find some very interesting data there.
Okay, thank you very much. Did you have an amendment? That
Yes.
I don't
Well,
have.
I liked Chairman
Okay, so
Newton.
his is good.
Okay.
Chairman Knight.
Amendment, Mr. Chairman.
Move to
Yep.
pass, Mr. Chairman.
Yeah, let's start.
Yeah. Second, all those in favor? Well, we got a motion, we're not gonna vote yet.
Right.
So, yeah. We have the First Amendment on the floor. Would you like to speak to your amendment?
Sure, I'll just offer that amendment that Betsy read earlier regarding the effective date. Moved up as soon as possible.
Okay, that's 1A, correct, Betsy?
That was one.
Oh, okay, section 2, okay. Effective on the signature of the governor.
Or his time expires.
Yeah.
The way she read it.
Betsy, you want to read the amendment, please?
Sure, this would go between lines 64 and 65, and it would say, this act shall become effective upon its approval by the governor or upon its becoming law without such approval.
Okay.
Mr. Chairman?
Yes, ma'am.
Before that gets any further, and Betsy, do we have to provide for effective date in line 5?
Yes, thank you, I'm sorry we do.
If that's a motion on his amendment, I'll second it.
Okay. All those in favor of the First Amendment, say aye.
Aye.
All those opposed? Representative Newton. Oh, Chairman Newton, Chairman Knight.
Thank you.
I get
Mr.
it.
Chairman, I would like
You
to
know
make a
your name.
motion to amend, make a second amendment here to this bill. Probably, and I'll get Betsy to help, because it's probably in place along where we just made that first amendment, but it would be adding a section D, and it would read, a retail pharmacy determined by the Department of Community Health to be an independent pharmacy shall not be reimbursed for a drug dispensed to a covered person for self-administration in the state health plan in an amount less than the average reimbursement for chain pharmacies reimbursed for the same drug.
For
It'd be F-64. Talking about
retail
section D.
pharmacy, Mr. Chairman.
Yeah.
Yeah, for our chain, well, I think chain pharmacy,
You said
yeah. Retail pharmacy, reimbursement for retail pharmacies reimbursed for the same drug.
Okay. Chairman Newton.
Well, I guess we need a second for the amendment first. I guess I'm just curious, the definitions of independent and retail or chain, and then the fact that chains may get, one that's owned by the PBM may get paid higher than the one that's not owned by the PBM. So that could be all over the place. I know it could be an average, but wouldn't the current language especially when we do the audit or the actuarial study, it's a little easier to clearly say one number instead of trying to do an audit on a number that we don't really know what next year's chain price is going to be, or alternate chain, PBM owned chain, and then independents. I mean, unless, actuarially speaking, I'm not sure how they estimate that as clearly as what's going on now versus what it would be with this other program.
Yeah, so Representative, thank you. What this is looking to do is obviously the actuarial study and implementation of a NADAC Plus is at best a year and a half out. And obviously independent pharmacists, to the representative's point, need help now and need help today. This problem was raised, obviously recently when we found it out. But the reimbursement problems that are illustrated in this chart continue day in, day out. And I'd also note right here, by the way, this is 15 more commonly prescribed generics. So these numbers are not cherry picked. But what this would look to do is basically say that a retail pharmacy determined by the department to be an independent pharmacy shall not be reimbursed for a drug less than the average reimbursement to chains statewide. And it's just looking to ensure that those community pharmacy doors are open in the interim. And so this would, again, it's not going to be the maximum. It's not going to be the $89 on the atorvastatin, but it's going to be that mid-range, an average of what those pharmacies are paid across the state. It's going to ensure that independent pharmacies are reimbursed no less than that. And the goal for that is to keep those pharmacy doors open and get some help as soon as possible.
I might add on the discussion, Mr. Chairman.
That's the amendment.
Would you propose that goes into effect upon signature by the governor? Because I do worry a little bit about in the middle of a plan year, the current language allows for the fact that you got to negotiate next year's plan from October, November, typical August and following. I would worry about trying to force SHBP to change horses, potentially in mid-April or sooner. That might give some reason for the bill to be vetoed, for example, or something like that. So it wouldn't accomplish what we're trying to. As much as I would appreciate, I agree with the goal of that. I would worry that would weaken the bill so much that it might induce a veto.
Yeah, our thinking on that is that this is the average price that pharmacies are being reimbursed today and every day in the state health benefit plan. Every day, this is the average price for what chains are being reimbursed. This doesn't change the program. What the goal of this is to do is to keep those independent pharmacy doors open.
And I think
So are you speaking to Representative Chairman Knights?
Yes, sir,
In
Chairman.
favor of his amendment?
Yes, Chairman.
And you don't think this is going to make it too heavy? Make the bill too heavy?
Well, I mean, is it changing the total, or is it just saying we're going to use an average?
Okay.
And I think that's the question. I think the state has entered into a contract where they got a bigger number and it's one total number. And as long as the PBMs don't go above it, they're fine. But within it, there's
Understand. Okay. Representative Kelly?
I guess just in the discussion for that amendment, and I appreciate Chairman Knight's direction and intent, I believe. My question is exactly that. Is your thinking that if that goes into place, and there'll have to be that meeting of the middle for both the retail and the independent, and that's what you think is going to keep the cost from ballooning on the state health benefit plan?
that would be my hope.
Okay. Do I hear a motion on the Second Amendment? No motion? This is the Second Amendment. We've already voted on the first. We're voting on Representative Knight's amendment. Do I hear a motion?
Could you repeat it so everybody understands what they're voting?
Could you repeat it?
I have everything's at the very end, so you might have to, so we're gonna add a new subsection D after line 64.
Right.
It says a retail pharmacy determined by the Department of Community Health to be an independent pharmacy shall not be reimbursed for a drug less than, I think, is it the national average?
So, shall not be reimbursed for a drug dispensed to a covered person for self-administration in the state health plan in an amount less than the average reimbursement for chain pharmacies reimbursed for the same drug.
Just, if we can
Chairman.
continue discussion, is that, are we still at a point with a motion? I guess I would really look at that. I'd almost have to withdraw my immediate, implementation because there's really no way to do that quickly. It would cause the prices to go up for the independents. That's good. I doubt there's any way to renegotiate in the middle of the year the chain farm prices that are out there now. Somebody would have a legitimate point to say this is going to raise prices above. I mean, I don't know how in the middle of a plan year you get a PBM to start redo all their contracts with independents immediately, raise them up to the average, and you can't bring down the other guys to the average because they've already signed a contract for a year. I would really worry about my amendment at that point as far as the speediest implementation of the study, and I would also really worry that a serious potential to increase the spending without the ability to get the commensurate reduction on the chain amounts, by the study. I think you're going to weaken the bill and endanger it.
You understand, Representative, and our thinking here is to the extent that it would increase the spending. Right now, independent pharmacies are dispensing in the state health benefit plan, and they're being cut to the bone, and as you heard, right? And so what this is saying is, independent pharmacists would be able to get the average of the rest. It doesn't dictate what the other chains would get. It would just look to protect independent pharmacists by ensuring they're being reimbursed no less than the average of all of the pharmacies in the state, instead of the disparate treatment that we're seeing today. And appreciate your concern and know you're a good champion on this issue and get the intellectual point. But our members are, again, we just found out today the third one closing this month. And so what we're hoping to do is that the will of this committee and the will of this body is to find a way to keep community pharmacy doors open today and address these disparities as soon as possible. And I think that's the concept of the amendment.
Thank you. Okay, we're going to take a vote on the Second Amendment because we've got another bill, and we've got to get these bills down to the clerk by 6:45. So, do I hear a motion on the Second Amendment? Second? Second. All those in favor say aye. All those opposed? No. Bill, Second Amendment fails. Back to the main bill with the First Amendment. All those in favor say aye. Aye. All those opposed? Congratulations, you have your bill. And
thank you, Chairman.
Let me repeat the LC on this, because it's probably 2 hours ago. LC 460820 as amended. Thank you. Okay, up next. I'm sorry, I can't hear you. I'm sorry. Interstate fuel. Okay. Up next is House Bill 1046, Representative Clark. You two are through. He's up.
Mr. Chairman, if I could, no, just kidding.
No. No. Thank you for being so patient. I appreciate it.
Chairman.
You're a good man. Go ahead.
Thank you, Chairman, and to the committee. I bring before you House Bill 1046. It substitute is LC 460849S. And I appreciate having the opportunity to, again, to present House Bill 1046 to the House Health Committee for your consideration, hopefully a favorable vote. At last week's hearing, we had many organizations testify in support of this very important legislation, which will remove the barriers from our health care delivery, as well as dealing with issues facing our funeral homes and families who have lost loved ones and are trying to get death certificates. Last week, if you missed the hearing, we had numerous groups testify passionately in support of this bill. Those testifying included the Nursing Association, representing the APRNs, and the Georgia Nursing Association, also the Georgia Nursing Leadership Coalition, physician's assistants, and a home health care agency, which also include a funeral home testified, the Alzheimer's Association, and Atrium Health. One physician testified against the bill, a plastic surgeon, and we will hopefully be able to address some of the concerns expressed by this physician. Just to briefly summarize the bill for those members who were not at the committee meeting last week, this bill actually is a bill that supports physicians by allowing them, if they want to delegate certain authorizations to APRNs and PAs, they would have the ability to do just that. The bill adds 2 new authorizations that the physician can delegate to APRNs and the PAs that they supervise, should the physicians desire to delegate those authorizations. So it's giving it to the physicians. First, House Bill 1046 authorizes APRNs and PAs to order home health care services, and we are one of 10 states that does not currently allow it for the health care services. Second, House Bill 1046 authorizes APRNs and PAs to sign death certificates, and we're one of 12 states that currently does not allow it. This bill changes the code to allow those physicians who supervise an APRN or a PA who they feel is qualified to delegate the ability to order the home health care services or the ability to sign death certificates. The physician would now have that ability. To emphasize the ability for APRNs or PAs to have this authority, it must be delegated by their supervising physician in a protocol agreement for APRNs and a supervisory agreement for PAs. Now, to just briefly summarize the bill, the substitute that you have for your consideration is LC, which is at 460849S. This includes several sections which merely adds APRNs and PAs wherever the code refers to a physician relative to signing for home health care or the signing of the death certificates. It also includes a section for the Department of Community Health and Department of Public Health dealing with home health care services and signing death certificates. In Section 7 and 9 includes a language in the code section for APRNs and PAs to add the ability for them to order home health care services and sign death certificates. With the ability for APRNs or PAs to have this authority, it must again be delegated by their supervising physician in a protocol agreement for APRNs and a supervisory agreement for PAs. There are a few other changes throughout the bill. There are a few spelling corrections and capital letter corrections. There are also a few words corrected in the bill which Legislative Council made, matching the changes to words so that they comply with the code. And then I'll also just add on the home health care services in 2020, when COVID hit, Governor Kemp gave an executive order allowing them to sign for home health care services. And so I think that even goes and shows even more that I haven't heard of any negatives. I mean, it was a positive. It helped expand health care, help those in need. And so I think we have those 3 years also just to show that it's very much needed. So at this time, I'd like to ask Robin Pidgeon to provide any further explanation of the bill.
Thank you, Mr. Chairman. Thank you, the committee, for letting us speak on this. I know our time is limited. I do want to ask that anyone here supporting our bill to please stand. We've had members driving here far away as well since 2 o'clock. They're very, very passionate about this bill. So thank you all for coming. We have members of the funeral home industry and the home health industry here to support us. I'm a nurse practitioner for 25 years. I work in the geriatric space. I order quite a bit of home health and death certificates across my desk very frequently. This bill is very important to the care of our Georgians. Right now, we have a crisis on our hand in this state, as I mentioned last week. We have primary care is collapsing, right? Even though there's a new medical school that's going to be opened, the first class is not going to be ready to graduate through residency in at least 10 years. We have to address the crisis now. I do want to emphasize, as we had a speaker in opposition last week testify that the physician would not be part of this plan of care for the home health or part of the death certificate. That is not true. During the CARES Act, allowed PAs and nurse practitioners permanently to sign the death certificate or the home health certifications and subsequent orders. We did so in this state for 3 years. We did so with very good outcomes. We did so still with that coordination of care with our physician. That did not change. So all of a sudden in April last year, when the PHE expired, all of us got these letters from home health agencies saying, you can't do this anymore. They had a scramble. They had to go back and change all their orders, change it to the physician. They've lost revenue, and patients in Georgia are not getting the care they need. Currently, since last April, physicians are not signing these orders. They're busy. They haven't seen the patient. We can continue where we were last April and continue to sign those and get these patients taken care of. Now, I do want to clarify, when we say nurse practitioners signing orders, these are nurse practitioners or PAs that are part of a medical clinic, a medical practice. This is not a nurse practitioner part of a home health agency. This is separate. So, in your folder, if you would please refer to your folder, we have a letter to the Governors Association when the CARES Act came into place. It's been signed by 2 medical associations, American Medical Directors Association and the American Academy for Home Health Medicine, and also other agencies as well. They do support this bill. We also have a letter from the director of Georgia Association for Home Health Association that supports this bill. And there's a talking point sheet in there as well. Can I answer any questions at this time?
Oh, Chairman Newton. Yeah, go ahead.
Thank you, Mr. Chairman.
Stinson.
Yes, sir. Thank you, Mr. Chairman. Can you speak to the portion relating to signing the death certificates on line 261? It states a physician assistant shall be allowed to make a pronouncement of death pursuant to authority delegated by the supervising physician. Will the supervising physician, how would someone know that the supervising physician actually gave the PA the authority to sign off on this death certificate?
That would be a question for the PA.